Hello and welcome. Today's discussion will be in hemolytic uremic syndrome. This is one of the major cause of acute kidney injury in children worldwide. This condition is preceded by some diarrheal illnesses, and then it presents with a triad of microangiopathic hemolytic anemia, thrombocytopenia, and acute kidney injury. So to define, hemolytic uremic syndrome is a thrombotic microangiopathy which is characterized by triad of 1. Microangiopathic hemolytic anemia, 2. Thrombocytopenia, and 3. Acute kidney injury. This condition was first described by Gesser et al. In 1955. And this is one of the very important cause of AKI in children which requires dialysis. Among the intrinsic cause of AKI in children, this is the most common. The common age is less than 5 years old children, and then sometimes it can occur even in the older children. HUS can be classified as typical and atypical. Typical HUS is also known as D plus HUS. This is associated with Shiga toxin, so also known as Shiga toxin associated HUS. In the children age group, this is the most common type. 90% cases of children are having this type of HUS. The common age is less than 5 years, with the peak being 2 to 3 years. This type is preceded by gastroenteritis, often a bloody diarrhea, caused by Shiga toxin producing bacteria. The Shiga toxin producing bacteria can be Shiga toxin producing E. coli, that is the enterohemorrhagic E. coli, with the serotype O157 is to H7. And approximately 80% of this type of condition is occurring in the developed countries, the European countries. And number 2, another is Shigella dysentery type 1. So this is most seen in the developing countries, Asian or African countries. And sometimes Salmonella and Campylobacter jejuni may also cause this condition. But common ones are E. coli and Shigella. The reason why E. coli is more common in developed countries and Shigella dysentery in developing countries are the Shiga toxin E. coli. The mode of transmission is foodborne transmission via the raw and undercooked food, which may be culture in the developed countries, eating a raw or undercooked food. And then large Shigella outbreaks are uncommon in the developed countries, whereas in the developing countries, the sanitation is poor and there is unsafe drinking water, and there is outbreaks of Shigella dysentery endemically. So this organism becomes more common in the developing countries. And the culture or practice of eating the undercooked food is also less common in the developing countries. So for this reason, E. coli is more common in developed countries and Shigella dysentery is more common in the developing countries. But both are Shiga toxin producing bacteria, which is responsible for HUS. Number 2 type is atypical type of HUS, also known as AHUS, sometimes D minus HUS. This is rarer type and this is not caused by the Shiga toxin. So this is not preceded by diarrhea. Here the main problem is complement. So this is complement mediated HUS. And this type of HUS, there is a high risk of recurrence and progression to chronic kidney disease and end-stage renal disease is high. So the prognosis is worse if the child has atypical HUS, but this is uncommon. And it can occur at any age, and usually it is occurring in the older children than the younger children. The clinical course is more severe than the D plus HUS. Atypical or D minus HUS again can be of 2 types. One is complement mediated and another is secondary types. in the complement mediated HUS, there is inherent complement abnormality or dysregulation of the complement, which is congenital or inherent. And the main causes or reasons which leads to complement dysregulation is number 1, genetic mutations. So these mutations occurring in complement factor H, complement factor I, C3, CD46, that is a cluster of differentiation gene protein involved in the complement regulation is CD46, and then complement factor B. So these are the main complement factors where the gene mutations occur and then leads to the dysregulation of the complement. And this type there is a high risk of relapse, and this type responds to complement inhibitors. Certain monoclonal antibodies are there which are complement inhibitors, so they respond to this. And this type of HUS is triggered by infection, pregnancy, surgery, organ transplantation, malignant hypertension, autoimmune disease, and certain drugs. Another type of atypical HUS is secondary HUS. Here, there is no inherent complement abnormality, but the underlying condition itself causes the endothelial injury, which is the main injury for the whole process of HUS. This can be caused by infections, mainly the Streptococcus pneumoniae with a respiratory infection, HIV, and less commonly cytomegalovirus, Epstein-Barr virus, and influenza virus can also be responsible. Medications like calcineurin inhibitors like cyclosporin, tacrolimus, or some chemotherapeutic drugs can be responsible. Autoimmune conditions like SLE, malignancy, pregnancy, organ transplantation, malignant hypertension, and radiation nephritis are the secondary causes for this type of atypical HUS. In this type of HUS, if the secondary cause is removed or treated, then HUS resolves. Has a lower relapse risk, and complement inhibitor is not routinely indicated in this, it will not work here. Let's see the etiopathogenesis of HUS. In typical HUS and secondary HUS, initially there is an endothelial injury before the activation of the complement system. So in D plus HUS, Shiga toxin first binds to glycolipid receptors, GB3 receptors, on the endothelial cells of mainly the kidney, and other organs that can be involved are brain, liver, pancreas, heart. So after binding to the receptors, it inhibits the protein synthesis and causes endothelial injury. Then there is a release of inflammatory cytokines and activation of the complement system. Whereas in the atypical HUS, if it is the inherent complement dysregulation type, then here there is dysregulation of the complement system and there is complement overreactivation. And in the secondary HUS, the endothelial injury is caused by the underlying condition or disease, and then ultimately it leads to complement activation. So in all three types, there is ultimately complement activation after the endothelial injury. So after activation of complement, it triggers the microvasculature injury with sequestration of platelets. So leads to formation of platelet-rich microthrombi in small vessels, which results in the triad of the HUS. So number 1 triad was hemolytic anemia, where there is RBC fragmentation while passing through narrowed vessel. The vessels were narrowed because there was a microthrombi formation which was platelet rich. So with the microthrombi formation, the channel becomes narrower. So in this narrow channel, when the RBC is passing, there is fragmentation and lysis. That lysis is mechanical damage, leading to intravascular hemolysis. Number 2, thrombocytopenia occurs because of the platelet consumption when they are forming the platelet-rich microthrombi. Then this microthrombi or microvascular thrombosis in the renal or in the kidney. Kidney was the main organ involved. So here renal microvascular thrombosis occurs, leading to glomerular injury, decrease GFR, and then ultimately acute kidney injury. So this way it forms the triad. The clinical presentations. If it is H plus or typical HUS, then this condition is having a prodrome of diarrhea and vomiting. Some diarrhea-like illness or dysentery will be there 5 to 10 days prior to the severe abdominal pain, and there can be fever. If it is atypical HUS, then this diarrheal episode will not be there. Then the child suddenly presents with a hemolytic anemia with a severe pallor and fatigue. Because of thrombocytopenia, the child will get bruising and petechial or purpuric rashes can be there. And with the AKI, they present with the oliguria, anuria, hematuria. There might be hypertension and edema. And sometimes there can be neurological features like irritability, seizure, coma in severe cases. In the physical examination, you'll find the child is pale, child has edema, petechial rashes, may have signs of dehydration also. Some have volume overload when the renal injury occurs. There can be hypertension, you'll get hepatosplenomegaly, CNS irritability, altered sensorium, and seizure plus minus in 3 to 50% cases. And some other organ involvement can also be there, so you'll get features of pancreatitis with a severe abdominal pain, cardiac dysfunction, myocarditis, and even colonic perforation can occur. Sometimes hepatitis also can occur. Okay, differential diagnosis. TTP is the closest differential diagnosis for HUS. In HUS, there is hemolytic anemia, uremia, and thrombocytopenia. Whereas in TTP, along with these three features, in addition, there is also fever and the neurological symptoms are there. In TTP, neurological symptoms predominate, and in the HUS, the renal symptoms are predominating. Otherwise, both have a very similar pictures. And sometimes HUS is even confused with the sepsis and DIC, and sometimes with the AGN, which also presents with the oliguria, hypertension, and then hematuria and edema also. And then sometimes vasculitis can be differential diagnosis, especially in the atypical types of HUS. Now investigations. First you see the evidence of microangiopathic hemolytic anemia. So the evidences will be shown by a peripheral smear. Here you will get cystocytes, helmet cells, Burr cells, distorted fragmented RBCs, and those are the key finding. After that, reticulocyte count will be increased, which is in all hemolytic anemias, that is a marrow response. And then there is increased lactate dehydrogenase, because you are getting in the hemolysis there is RBC is getting lysed, and then RBC LDH is present in RBC in high concentration. So there is increased lactate dehydrogenase. And decreased haptoglobin, because haptoglobin is binding with the free hemoglobin. With the lysis of RBC, hemoglobin is getting released, which is bounded with the haptoglobin. So the level of haptoglobin will decrease. And there is increased indirect bilirubin, that is due to breakdown of the heme. After the hemoglobin is released, that will break down to heme. So because of this will be converted to the indirect bilirubin. So bilirubin is increased. So all these are evidences of microangiopathic hemolytic anemia. Number 2, if you do complete blood count, then you will get neutrophilic leukocytosis, hemoglobin will be low, and thrombocytopenia is present. Then if you do DCT, direct Coombs test is negative in case of HUS, because this is a non-immune hemolytic anemia. So this is to exclude whether the hemolysis is immune mediated or non-immune mediated. In HUS, it is non-immune mediated hemolytic anemia, so DCT will be negative. Then evidences of renal injury or AKI will be evidenced by the serum creatinine which is raised, urea is also raised, electrolytes, there might be hyperkalemia and hyponatremia, there can be metabolic acidosis, and then in routine microscopic urine will show you hematuria, as there is a glomerular injury in AKI with the proteinuria, and with the intravascular hemolysis you might even get hemoglobinuria, which is lesser than microscopic hematuria, and there might be casts also. Then investigations with the specific etiology. So if you suspect typical, you'll select one like that. So if etiology you suspect Shiga toxin mediated HUS, then you send the stool or rectal swab for culture for isolation of the Shiga toxin producing bacteria, where you may get E. coli as well as Shigella. So whichever is common in your setup, you expect that organism. And PCR for Shiga toxin in stool can also be done. And for atypical HUS, complement studies are essential. So complement genetic testing can be done mainly for complement H, I and C3, which will be low. And then membrane cofactor protein CD46 can be tested. Complement pathway evaluation can be done. Anti-factor H antibodies are also assessed or evaluated. DIC is one of the differential diagnosis. So you send test for DIC also, where there is a prolongation of PT and APTT, decreased fibrinogen and increased D dimer. And if the cause, if you suspect to be secondary cause, then you need to do autoimmune screen, ANA, dsDNA, antiphospholipid antibodies, complement C3, C4. And if the cause is infective or infection is there, then you do infection workup, especially the cultures. Blood pressure workup should be done. Liver enzymes may be increased, so you might expect increased transaminases. If there is pancreas involvement, then elevated amylase lipase, and then cardiac enzymes for cardiac involvement. Neurological assessment, CT and MRI brain can be done if there is a neurological involvement. And roll of kidney biopsy, it is rarely required and rarely done. Sometimes if the diagnosis is not clear, then only you need to do kidney biopsy, otherwise this is not done routinely. So these investigations, the etiology specific investigation you do not do for all children or all individuals. Based on the history and your physical examination, you select some of the investigations as per the etiology. And serum antibodies to the lipopolysaccharide can be done, especially this is helpful in the Shiga toxin associated HUS, that is the typical HUS. Lipopolysaccharide is the outer membrane endotoxin of gram-negative bacteria, especially the E. coli O157H2H7. So here it detects the antibody, that is the IgM and IgG antibodies against the O-specific lipopolysaccharide. So that is specifically antibody detection against the O antigen. So this is helpful only if it is Shiga toxin associated HUS. Now come to the treatment. There is no definite treatment for HUS. Treatment is supportive and symptomatic, especially in the typical or D plus HUS. So here volume repletion, you need to give adequate hydration if there is a dehydration. But if there is again AKI, then you have to give insensible loss with the previous day's output. So depending upon the condition, you will select or you will deplete the volume. And then control of hypertension if there is high BP. Packed red cell transfusion is done if hemoglobin is less than 6 gram per deciliter. Treat dyselectrolytemia. Maintain the nutrition. If there is convulsion or seizure, then treat or control the seizures by the anticonvulsants. And renal failure, you go with the peritoneal dialysis, and in case of children, peritoneal dialysis is quite helpful. For atypical HUS, some specific therapies are available. If it is atypical or recurrent HUS, then plasmapheresis or plasma exchange can be helpful. Patient with the anti-factor H antibodies, immunosuppressive drugs is useful, or it is used as it reduces the antibody production. And HUS, which is associated with the activation of the complement cascade, that is the inherent complement dysregulation HUS. In this, the monoclonal antibody, which is C5 inhibitor, eculizumab, is used, and that is indicated. And some therapies under trials are IVIG, that is intravenous immunoglobulin, steroids or antioxidants. And to remember, antibiotics, antidiarrheal agents will increase the risk for HUS. Hence, these two drugs should be avoided if you are suspecting HUS, especially the Shiga toxin producing HUS. Because antibiotics, if you give, it will lyse the bacteria, which will increase the Shiga toxin and aggravate the HUS. Antidiarrheals, if you use, it will decrease the gut motility, so there is more toxin absorption, so more chances of HUS. Always avoid these two drugs if you are suspecting typical HUS. Now the complications. The renal complications can be CKD with end-stage renal disease in 5 to 9% cases. Extrarenal complications in central nervous system can be irritability, seizure, coma, infarcts in the basal ganglia and cerebral cortex. Gastrointestinal complications can be colitis, perforation, intussusception, hepatitis. In the pancreas, there can be focal necrosis, glucose intolerance, ultimately leading to insulin-dependent diabetes mellitus. Cardiovascular system, there can be arrhythmias, myocardial dysfunction, pericarditis. The prognosis for H plus HUS or typical HUS is better. More than 95% survive the acute phase and then recover with a normal renal function. Whereas around 5 to 9% cases there might be residual renal defects with proteinuria, hypertension, chronic kidney disease and end-stage renal failure. And less than 5% is the mortality. Whereas the atypical HUS has a worse prognosis. Here mortality is 25%, progression to end-stage renal disease is 50%. Familial cases and sporadic HUS have a poorer outcome. With abnormalities in the CD46, there is chances of more relapses. So finally, the key points for HUS is, most common cause for HUS is Shiga toxin producing pathogens. That means typical HUS is more common than the atypical HUS. In HUS, the hemolytic anemia is Coombs negative. That means non-immune hemolytic anemia. And then in HUS, try to avoid antibiotics and antidiarrheal drugs, especially in the typical HUS. And eculizumab is the first line drug of choice for atypical HUS. Okay, thank you. I hope this class was useful for you all.